This conference will now be recorded.
Good morning, everyone. Are you able to listen?
Yes, ma'am.
Is anyone there? Okay. So I think in the last class we have discussed about the large vessel vasculitis and medium vessel vasculitis. We have yet to complete the small vessel. Then we can go whatever the topics which were displayed for you last couple of weeks. Okay. So a small revision, if you can remember, what is large vessel vasculitis? What are the vessels which we can call them as large vessels? Aorta and the branches of aorta, they are the large vessels, and the diseases involving the large vessels are giant cell and Takayuki. And the medium vessel is something which is arising from the aorta, from the branches of the aorta and till the precapillary terminals of a vessel, that is medium vessel. Whenever you're dealing with precapillary, postcapillary venules and the capillaries, then that is the small vessel vasculitis. So medium vessel vasculitis is polyarteritis nodosa Kawasaki. It comes under variable vessel vasculitis Kawasaki, and small vessel are antiglombular basement disease as well as ANCA-associated vasculitis, which is usually a small vessel vasculitis, and sometimes the medium vessel can be involved, but usually it is a small vessel vasculitis. Are you able to hear me? If any problem, just let me know. Okay. Okay, coming to the like as I told you already, the large vessels are giant cell and Takayasu, medium vessel is Pan and Kawasaki, small vessels are Anka, eosinophilic granulose, that is Strauss, and then Priyanka Sianka and IgA vasculitis, etc. fall under this category. 1 minute. Hello. సునీత గారు క్లాస్లో ఉన్నా, నేను క్లాస్లో ఉన్నా. లేదు ఇప్పుడు నేను ఇప్పుడు చేస్తాను. And we have already discussed about this, that giant cell vasculitis is the temporal vessel vasculitis, which is most commonly involving the temporal vessel. See, if you see the patient, they usually come with the one-sided severe headache, which they complain like almost while eating or anything. They just complain of severe headache, and you can see a bleeding or like some swelling of that particular vessel. So whenever the patient comes with this kind of picture and he says blurring of vision, we should never neglect the patient and immediately start on the steroids, because if we neglect that patient, the blurring of vision can progress to complete blindness, which we could have prevented just by giving the steroids in this case of vasculitis. Okay. And also biopsy, the best gold standard investigation for this is biopsy, but if we delay without giving steroids just for the diagnosis of temporal artery vessel vasculitis, then we are going to do harm to the patient. We can do the biopsy within 2 weeks of starting on steroids, so it is important that you catch the case and not let the vision go down. And also giant cell arteritis patients are more prone to polymyalgia rheumatica, which is a condition with severe myalgias and arthralgia involving mostly the proximal muscles. Usually both of them are associated, but without giant cell arteritis also there can be polymyalgia rheumatica. And for that, for that also the treatment is steroids. But the difference is for temporal vessel vasculitis, which is involving the vision and all, you give high dose like 1 gram of steroid. Whereas for polymyalgia rheumatica, it is a low dose steroid which you keep in a daily doses. Okay. So that is something important about this. And if you see these cases, the ESR is usually very high. And I already showed the pictures of arthritis nodosa, which usually present with this typical diganglion picture. With this is some purpura. Whenever you see some blanching rash, which is palpable, that is palpable purpura, which usually occurs in case of the conditions which is not associated with the platelets. That is, which is vasculitic related. Palpable is nothing but vasculitis, like that you can remember. It is to do with the small vessel vasculitis because of immune complements depositing in the vessel. And also you can see this might be a picture of livedo reticularis, which is not clearly seen, or like okay, I'll show you a better picture. And these are the vessels found on the lateral malleolus side. Here you can see the narrowing of the vessels in this. That is what they are trying to show. And the beading appearance and the narrowing on the other side, beading like those and all occurs in case of aneurysms, and beading like appearances occur in case of polyarthritis nodosa. Next, coming to Kawasaki, you have it is usually seen in children with vasculitic rash for the face, hands, etc. And the tongue is called as strawberry tongue. Now, coming to the small vessel vasculitis. Um, The small vessel vasculitis, as we already told, like it is ANCA associated. ANCA is two types of ANCA are there, P ANCA and C ANCA. C ANCA is only with vagueness, whereas P ANCA occurs with that of except PAN. I mean to say the large PAN. MPAN has MPAN, EGPA has P ANCA associations. Church straws. This is Church stroke or eosinophilic granulomatosis with polyangiitis. Here there will be a picture of, they will give you a question which tells like a middle-aged person, either male or a female, usually a female, comes with a picture of bronchial asthma along with sinusitis. And if you see the blood picture, there is eosinophilic preponderance along with the pulmonary infiltrates and cutaneous eruption, or like you can say palpable purpura here also. Along with that, there can be some pericarditis or cardiomyopathy or MI, and along with that, there can be like a single nerve involvement of the lower limbs, peripheral neuropathy. That is what they are telling. And this is a picture of a patient. Whenever you see a patient who is there complaining of asthma picture, not from the early childhood, but which developed in the middle age, along with multi-system involvement, then you have to think of with the hypereosinophilia, think of the condition of EGPA. See, as usual, when you take a chest X-ray, there can be pulmonary infiltrates. In the CT also, you can see like a mixed picture of honeycombing, and then you can see the picture of purpura over the back. So this is the criteria which was given earlier, but yeah, it holds even we follow the same, like asthma, eosinophilia, more than 10, how much more eosinophilia? More than 10% in the peripheral. Below that, what can you think of? Any other allergic conditions like strong amyloidosis, any parasitic infection, you can take it into consideration. And then sinusitis. pulmonary infiltrates, and histological proof of vasculitis with extravascular histologies. These are all we discussed. And as we already told, like EGPA comes under Priyanka. 70% of the patient can have Priyanka, and eosinophilic preponderance can be seen with the anemia as a picture of a long-standing anemia of chronic disease, with elevated ESR and disease activity correlating to. And for this, the gold standard will be anyways biopsy, but we shouldn't wait for biopsy. The picture of X-ray with the hypereosinophilia and ANCA suggestive for the diagnosis. You can say it is a bad prognosis when the patient has heart failure or MI, because rarely it can involve the heart. The eosinophilic deposits can occur in the heart. Whenever they go there, the interleukins, everything, the cytokines occur there. Because of that, they tend to prone to more amount of damage, either as cardiomyopathies or pericardial effusion, causing sudden cardiac morbidities. Along with that, there can be renal failure, cerebral hemorrhage, and gastrointestinal bleeding can occur. Status asthmaticus. As I told you, the picture starts as asthma. Status asthmatic picture can be occurring. That is with the EGPA, as we have seen before. Now coming to the Wegener's granulomatous, it is relatively rare, but like coming to the picture, as we decided, as in India, we do see cases, but most often when we see the cases, most often we will be thinking in our notion that it is tuberculosis because of the picture which is a bit depicting, and tuberculosis is much common over here because of hemoptysis and chronic progression of the disease, along with the extra pulmonary manifestation which this disease has, correlates with that of tuberculosis, and sometimes often it's misdiagnosed. But it's a long-term thing. Wegener's granulomatous with tuberculosis, it's an infection. It's not like for a long term, just it depends on how effective the treatment is. Coming to the classical triad, Wegener's, how do you diagnose it? It is an necrotizing granulomatous vasculitis of the upper and lower airways. You have to remember, like in EGPA, I told you bronchial asthma is there, which means that lower airways are predominantly involved. In Wegener's, I'm concentrating both upper and lower airways, which means that both the nasal cavity as well as the sinusitis as well as the lower airways in form of hemorrhage, cavity, etc. can occur. Along with that, there is systemic vasculitis and focal nephritizing glomerulonephritis. Okay, and how does this patient present? Usually, the upper airway lesions are in form of sinusitis and nasal drainage, ulceration, septal perforation, and cartilage destruction can occur. Because of cartilage destruction, saddle nose deformity can occur, and then can be otitis media because of the difference in the pressure changes in the nasal area, which can lead to stagnation of secretion, which can make up the bacteria buildup and causing otitis media. So, where else can you find saddle nose deformity? I need one answer. Are you all there? Where do you find saddle nose deformity? Just give me in the chat box if Down syndrome, congenital syphilis. Something more common which you see. In Down syndrome saddle nose, they usually have the deformity, but it is not the saddle nose deformity. Congenital syphilis, it is now syphilis almost we don't see. Something which we are seeing. Sometimes an elderly person comes and sits in the derma OP or like comes to a medicine OP. What is that condition? Which we see. Any infection. Okay, I'm giving you another hint. Infection. Which infection can present like that? Yeah, very good. Anju. Yeah, it's Hansen's leprosy. So, yeah, that is the answer I wanted. And usually, even the single nerve involvement can also occur in Hansen's. So, this can be DD for that in the initial stages, not like full blown infection. Sorry, full-blown disease of Wegener's. So that is how it can occur. And then coming to tracheal inflammation, because of tracheal inflammation, there can be subglottic stenosis and lung involvement in cough, dyspnea, hemoptysis, massive pulmonary hemorrhage, which can be life-threatening. Actually, I had a case when I was in post-graduation where the patient from past 3 years initially had in the nasal septal area some perforation. He was diagnosed as tuberculosis and was put on ATT. And because of ATT, there was no difference, but the ATT was removed after 6 months, and he was okay, but he was not doing as good as he used to do, like when he was in 30s. He presented at his 36 age. Later, after the first episode of that, the second episode started with again nasal bleeding, epistaxis. For that, he went to the local hospital and they again told it in form of tuberculosis, and they started giving him tubercular medication again. And third time, he presented with a severe shortness of breath, for him, which he came here as. He was intubated, and the moment intubation was done, the blood in his lungs was pouring out because of massive pulmonary hemorrhage. Usually, the rupture of the capillaries can cause the bleeding, and the bleeding usually stays in the alveoli. This bleeding is a microvascular bleed, right? So they usually stays in the alveoli itself. And usually they can't cough out blood, but if you put in, the blood will be, you can find out the blood, and on the X-ray, the pulmonary hemorrhage can be seen. Like as a not like a hemorrhage, but like some opacity, because the whatever the blood it is draining out, it is collected in the alveoli. This one you have to differentiate it from that of uh, hemoptysis of that of tuberculosis. In tuberculosis, the hemoptysis is because of rupture of bronchial vessels, which is a bigger vessel than Wegener's. So what happens is massive amount of blood is coming, and where the patient is stimulated to cough, and he coughs out blood. Whereas in this Wegener's, they usually don't bring it out. If you put inside ET tube or anything, they just bring it. It just comes out, but they won't usually cough out. Whereas in case of tuberculosis, it's like they cough out the blood. I hope you understood. This is a very nice scenario in case of knowing the diagnosis. And if we see the investigations, usually there will be normocytic normochromic anemia with leukocytosis and thrombocytosis, and there will be elevated ESR, Wegener's associated with CNK, and this CNK has a strong positivity here. If you see CNK, usually usually CNK is positive only in this case of Wegener's. Rest of the cases, it is Priyanka. So something it is typical. What is CNK? It is but plasmic. No, actually, this PN CNK, cytoplasmic, AN is antineutrophil. Like it and all are like not the ones which we It was initial stage, we named it as neutrophilic, and one minute. Hello, class member. So initially it was named as neutrophilic and cytoplasmic, but it is not actually the neutrophilic and cytoplasmic. But later on it was named in that way, but later on we came to know that it is more associated to both the neutrophilic and cytoplasmic. The nuclear component, which is cytoplasmic, there is that is why P is perinuclear, cytoplasmic, perinuclear. Those are not just overlapping. C is antiproteinase. These antibodies are directed against PR3 or antiproteinase 3 antibodies. And the titers usually correlate with the disease activity. And biopsy specimen shows the diagnostic granuloma. Okay, this is a granulomatous vasculitis. So these are the lab investigations. If you see the picture. This is a saddle nose picture. You can see saddle is, right? Saddle in the form of saddle, the deformity. And you have the purpuric lesion around the eye. Usually, this typical picture you see in dermatomyositis. And then you should have kept the nasal cavity or nasal septal perforation, etc. This occurs because of nasal septal perforation. And these are the cutaneous manifestations, small muscle vasculitis in form of purpura and purpura. And this, if you see, there is a granulomatous formation in this one, in the biopsy specimen. And this is the ocular manifestation in form of scleritis, episcleritis. These are usually seen in this pregnancy. Usually, one point to add up, scleritis, episcleritis are more to do with vasculitis. In rheumatoid, you can see uveitis. And here there's a picture of CT chest with a cavity, and filled with the cavity along with some opacity. Usually the cavity, these are blood-filled cavities which you can see in the CT for diagnosis. And coming to the last few slides, and this is HSP, which is also called as IgA vasculitis. Now we just use the HSP as IgA vasculitis, and it is one of the most common hypersensitivity vasculitis of childhood and young adults. In the young age population, you do see it. They usually have first, they start with upper respiratory tract infection, and after that, there will be some stimulation of the immune complexes or hypersensitivity reaction occurs, which targets the vessels or small vessels where the immune complexes are deposited and leading to this picture of the chest. Boys and girls are affected equally, and the median age of onset is around 40 years. And it's a self-limiting in course in most of the patients, but very few patients can have renal involvement in the future courses. If the renal involvement occurs like after the particular episode of respiratory tract infection and IgA vasculitis, the hematuria continues further along with proteinuria. It is something to be taken seriously, but usually it is self-limiting. And the triad is usually you have the palpable purpura with a normal platelet count and colicky abdominal pain and arthritis with or without fever. Usually the respiratory tract illness comes initially. That disappears. By the time it decreases, the immune system or immune complements are formed. These immune complements are deposited in different small vessels. They lead to palpable purpura. Platelet count will be normal only because platelets are not distinct. It is the vessels which are distinct. Along with that, because of involvement of abdominal vessels, we can have colicky abdominal pain, which can lead to melena or hemorrhage. Along with that, they can have generalized symptoms of arthritis and fever. In the arthritis, also small vessel involvement can occur, and arthritis can involve severe painful knees. And palpal purpura first appears on the lower limbs in the dependent areas and buttocks. Though the purpura are not palpable, palpability depends upon whether they are raised from the surface or not. Not just because your finger is able to identify the raise or not. Because our finger can't identify the minute changes in the elevations and all. So palpable purpura is not like which is an organ which you palpate and get into hand very easily. Sometimes they might not be palpable, but they are elevated from the skin surface. That is the reason they become palpable purpura. And then arthritis is transient and usually involves the knees and ankles. See, this is almost like a rash. It's like a swept over rash, right? This area you can see like it's like swept out. That is how they are going to be. Hemoptysis is seen in 1/3 of patients and 50% of the patient have occult gastrointestinal bleeding. Why? Because of the rupture of vessels in that what is this? Rupture of vessels in that uh, in the abdominal cavity. And in 10 to 15% cases, there can be renal involvement from transient microscopic hematuria to RPGN. How do you do? As I told you, if the initial stages there will be microscopic hematuria, but if it continues beyond the age of 10 years or beyond the age of 15 years, if there is microscopic hematuria, if there is hematuria along with proteinuria, then you have to think like there is something bigger picture is involving the kidney. They can usually have RPG, rapidly progressive glomerular nephritis. And then how do you diagnose the case? On the clinical grounds, what did I say? In the clinical grounds, there should be a palpable purpura, there should be arthritis along with or without fever, and abdominal colicky abdominal pain is also a must condition for to diagnose this condition. And skin biopsy should be taken to identify the vasculitis and the immune complex deposits. And the lab results show elevated ESR complements, immune complex deposition, and IgA. It is seen in the biopsy. And the treatment is usually supported because not all the patients will progress to RPGN. So initial stages, it's for a respiratory tract infection, you just give some, if the patient presents at the respiratory, you give some antibiotics. And no, it is not that respiratory tract illness, it is only the IgA vasculitis which he came to. Then usually it is a supportive management with hydration and monitoring. If at all the pains are very severe, then give NSAIDs. But see, abdominal pain and melena are all usually common, but NSAIDs, adding up NSAIDs can elevate the problem of gastrointestinal bleed. So it's better you can go with the steroids of 10 to 30 mg per day for abdominal pain, edema, and nephritis. Okay, bowel edema also occurs because of this. And so that is how you deal. But if there is persistent hematuria and the patient is developing RPGN, then go with the higher dose, which will be around 10 years later of the initial episodes. Now coming to variable vessel vasculitis. Among the variable vessel vasculitis, the first thing which you remember is Bechet for your thing. Bechet is also a condition which is commonly seen in the younger age. And the most important diagnostic criteria, and the one diagnostic criteria which you cannot be missing is the oral ulcers. Oral ulcers are the mainstay of diagnosis of Behçet. Along with the oral ulcer, you can have genital ulcers and vasculitis. But as you see, this is the ulceration over the upper labia, and these are healed out ulcers. In diagnostic criteria, first there should be recurrent oral ulceration. That is some mandatory thing. Along with that, you should have any two of the following: either recurrent genital ulceration or ocular ulceration. Okay, oral ulceration is observed it should be identified by a rheumatologist or a physician, which should have occurred for 3 times, more than 3 times per year. Along with the oral ulceration, which is recurrent, there should be recurrent genital ulceration. After this ulceration is there, which is complaint, and ocular lesions in form of anterior uveitis or posterior uveitis or in vitreous on slit lamp examination of retinal vasculitis observed by ophthalmologist. If you have oral plus recurrent genital ulceration, see, don't forget to see the fundus. You might find retinal vasculitis. Along with that, discolorations in form of erythema nodosum can be observed. Erythema nodosum is nothing but pancreatitis, subseptal pancreatitis, whereas pseudofolliculitis, papulopustular lesions, or acne form lesions can be seen. And there can be positive pathology test. What is positive pathology test? Whenever you perform it with there is some problem with this. You take a needle under sterile conditions and you take a new normal saline and you just inject in the particular area, and you should observe it after a 48 hours period. In that particular area, it starts to separate out the layers. That is the positive pathology test, which is usually seen in case of Behçet disease. These are the recurrent ulcerations in the joint area where the erythema nodosum can be seen. This is the erythema nodosum. And then principles therapy. And for for Behçet also, the treatment is usually the steroids initially, and then go for IVIG to the extent where you can stop the offending antibodies or decrease the effects of the antibodies. And whatever diagnosis we make in terms of the identifying the cause, and then you have to halt the disease progression and treat the primary underlying disease. Usually glucocorticoids are sufficient to manage giant cell and tachycine and limited polyarthritis without any visceral involvement. Indications for cytotoxic drugs. Where do you use cytotoxic drugs? As a cyclophosphamide or as a triptan or rituximab? Whenever the disease is rapidly progressing with significant visceral involvement, either in case of Agnes or Bianca or Sianca, because of that, in that cases, where the disease is rapidly progressing, you have to halt that. Steroids are not acting. Then the next choice is induction and maintenance regimen of these cytotoxic drugs. Either you can use a cyclophosphamide, then thiopurine, or like you can use rituximab and then maintain with azathioprine, like that it can be treating. And then disease which is refractory to corticosteroids or rapidly progressive. This and all of the indication for cytotoxic drugs, and inability to reduce the steroid dose in spite of putting on steroids for a particular 3 to 5 days course. And then for vasculitis, remission induction, usually you give cyclophosphamide of around 2 milligram per kg for 3 to 6 months period, or 15 milligram per kg IV, which is given twice weekly, the 3, and then 3 weeks, and for once 3 weeks every 6 to 12 months, and this is continued for 12 months. or 6 to 12 months. So whichever the regimen, there is favorable regimen, there is favor with the short duration compared to this because of maintenance issues. Prednisolone can be added up to the cycle of plasmid. If not, along with that, you can just supplement with calcium and vitamin. This is for induction. After the induction, there should be maintenance. Induction is nothing but you're bringing down the disease activity. After bringing down, you should completely eliminate it. How do you eliminate it? With the maintenance therapy. The maintenance can be done with either methotrexate, azathioprine, mycophenolate, and leflunomide. But usually we prefer azathioprine, if not MMF. These two are main. Azathioprine 2 mg per kg orally, or mycophenolate MMF 1.5 gram per oral PT. These two can be given. MMF has been used as maintenance therapy for redness and microscopic pan. So, but usually most of the things it is cyclophosphamide, but in certain cases you think the cyclophosphamide is more toxic as the reproductive age female and all, then you can think of course this is also toxic, but you can think in terms of mycophenolate mofetil. Then IVIG and TNF blockers may be used in resistant cases can be done in plasma for acute management of severe vasculitis in case of Kawasaki, etc. How do you know that this patient is having the vasculitis syndrome? Patient with multi-system involvement, he presents with all the characters which we have discussed before, and with the clinical pattern supporting lab diagnosis, and there is offending antigen along with it. Then remove the antigen. If not resolved, then you have to treat in terms of vasculitis. Uh, just establish the diagnosis of what is physical vasculitis, because there is overlap and there is also a tiny bit of difference among all this vasculitis. So as far as possible, there will be not no much problem in diagnosing it as large, medium, or small. But up to there, you will do it. But whether it is Takaisu or giant cell arteritis, sometimes can be misleading when it is involved in the aorta and its branches. So uh, that time it needs further biopsy in order to look into what the exact diagnosis is. And also tissue biopsy, angiography, just to know the bleeding appearance or where else the lesion is involved, or the PET scan to know granulomas wherever they are. These all are help. These all help in aiding the diagnosis. Diagnosis what for? Treating. Treatment is nothing but induction with the steroids or induction with the cytotoxic drugs, and then maintenance with the azathioprine. Now these are this is a question scenario. I'll just tell you. You give me the diagnosis. It's a child who complaining of arthritis, palpable purpuric eruptions, and abdominal pain and GI bleeding, along with the hemoptysis after respiratory tract infection. What is your diagnosis? You can put in the chat box. Diagnosis. No one is answering this. Up to now, we discussed that only. Coming with palpable purpura, complaining of colicky abdominal pain and arthritis with some amount of GI bleed. What do you think? What is your diagnosis? Even it's a mistake, it's okay. Just put some answer at least to know that you people are listening to me. Very good. IgA vasculitis. Just a revision. This is a quick one. I don't want to take more time on it. As fast as you give me the answer, that fast we can do this. And this is a case of female patient, engaged female patient, who is having history of asthma, allergic rhinitis, atopy, peripheral neuropathy, cutaneous eruption, and pericarditis. Cardio and myocardial infarction with the hypereosinophilia and Priyanka first. What is your diagnosis? Chat box. What is the diagnosis for this question? I told asthma, history is there, rhinitis or atopy, along with that pericarditis, cardiomyopathy, peripheral neuropathy, cutaneous eruptions, like allergic rhinitis or asthma type of picture they are presenting. What is your diagnosis? This we discussed already, I suppose. Is it Wegener's or is it EGPA? Answer. I told you either it might be wrong or so I won't say anything. Anyone can answer. I'm not getting any answer in spite of me telling all the class. No answer. I discussed this point very clearly, telling whenever you have asthma, you think it in that form. Whenever you have upper respiratory, lower respiratory, you think it in other form. I just differentiated when I was telling. No one listened. Jerk straws. See, you're taking so much time. Okay, good. But do I have to ask you these many times to just get an answer, single answer? And we already discussed about Jane cell, I suppose. And then what do you, this is the last one for you. Last but two. There is recurrent oral ulceration more than 3 times per year. Genital ulcers are present. Uveitis with cells in the vitreous and retinal vasculitis is present with superficial thrombophlebitis with erythema nodosum and papulopustules. Pathology test 2mm positive. What is your diagnosis? Don't say present at the ending of my class. Either you say present or say it in the beginning, or after my class is over, say present. In between, if I ask questions, you type the answer, not present all the time. Diagnosis of this particular question which I told you. Any answers? See, clearly, I'm repeating again, there is recurrent oral ulcers and recurrent genital ulcers. Along with that, there is erythema nodosum and thrombophlebitis. What is your diagnosis? Yeah, very good. Soni Madri, she is doing good. Behçet disease is the one which is going to present in that form. Okay. Then coming to the next one. There is new nasal, yeah. With the same single word, you can say the diagnosis. There is nasal cartilage ulceration, nasal mucosal ulceration with cartilages deformity, which is leading to saddle nose deformity with otitis media. There is cough, dyspnea, and hemoptysis. Massive pulmonary hemorrhage can occur with hematuria, proteinuria, CRF, or chronic renal failure with fever and weight loss, which is long duration, with cutaneous purpura, peripheral neuropathy, arthralgia. And C. ANCA is positive. What is your diagnosis? Very good. It's Wegener's disease. And this last one, a child of 5 years, less than 5 years, is complaining of arthritis and acute onset high fever with bilateral conjunctival congestion and strawberry tongue and painful cervical lymph nodes, exanthem on trunk, along with carditis and heart murmurs and IHD. There's also abdominal pain, vomiting, and diarrhea. What is your diagnosis? Just leave about everything. Just think only arthritis is there. High fever with bilateral conjunctival congestion and strawberry tongue. What is your diagnosis? Kawasaki. Very good. So that is the thing with the vasculitis. So by today we have discussed all the kinds of vasculitis. So most of the rheumatology part will be done. So next classes we'll be discussing about those things which you have seen in the previous few classes as a PowerPoint presentation which were given to you. Okay, so just go through whenever you have time because the ocular manifestations also will be there. So whenever you're reading ophthalmic scleritis, episcleritis chapter and all, you can just correlate so that you remember it more. Okay, thank you.